surgeons. So please join us in the future if you want to have ME credits. Please do it all access pass. So coming 2025, please keep tuning in. Content, high quality, always available. Please use the all access pass if you need to claim CM credits. Thank you so much.
And we're live in 5,
4, 3,
2,
1.
Well, good morning, everybody. My name is Jens Abman, and today is March 5th, 2025, and I will welcome you to this edition of our Talk Spine Technology Education Discovery Debate. And again, this is a very important forum. We can have different exposures, different experiences, and case-based debates all in one session. It's a fantastic honor and pleasure to introduce Dr. Richard Wohns. He's being cut in his logo here. Dr. Wohns is the only MD, MBA, JD that I'm aware of, and a fantastic example of somebody who has an open mind and is keen to discover and move the world. So welcome, Richard, and thank you for joining us this morning.
Thank you, Jens. Pleasure to be here.
He's the founder and president of Spine, which has a very large footprint here in the Puget Sound area in Washington State. He's a neurological surgeon, but a spine surgeon par excellence, and he has an amazing background. I'm going to introduce in greater detail a little bit later when he starts his talk about bringing spine surgery into emerging, developing countries. He's done that with in Nepal and in the Maldives. And we're curious to hear about that because he made an actually huge imprint there. To start things out, we're honored to have visiting spine surgeon here, Dr. Maya Laishena. He is from the Mwai Kibaki Hospital in Kenya, and he's going to be with us for a month, and we thank him for his time here. It's great to have you here, and he has a couple of cases. He's just going to show us one case, Richard, and we'll just discuss for a second. And we have a couple of cases from our fellows that Dr. Osun selected with our fellow follow right after that. So great to have you here, Jeremiah, and take the microphone, please.
Thank you, Dr. Jens, and thank you, everyone. I'm happy to be here. So I'm going to present a case I saw and did a month ago. It's a case of spinal anastomosis. So that's my hospital in Kenya. So it's an ex of the Kenyatta National Hospital. Dr. Jens and Oscar know because they've been in Kenya times back. So I have no disclosures today. This is a picture I took of some traveler. I was going to work, and at this point I was wondering, who would I call if something happened? Neuro, is it ortho, trauma, or maxillofacial? These are some of the dangerous things that we find in sport in our country, and quite a trauma. I'm presenting a patient by name MK. She's 65 years old female who presented to me with a 5-month history of low back pain, and she was complete. This pain was really worse when she was walking, and she would walk like a distance of 50 meters, and she would feel so much pain and some weakness. And she also reported that was relieved by bed forward or sitting down. And also she had to do, when she was doing activities, she would want to just lie down and to relieve the pain. She reported no bowel sound, no bowel and bladder function, and she had weight loss, which was a bit concerning. But on further history, we realized that she was seeing gastroenterology because she's been having these prolonged diarrhea, but nothing. Nothing that was, everything was ruled out that it was probably just IBS. Yes. She hates sweats, and she's a non-smoker, no other commodities, and doesn't use alcohol. So on physical, just no deformity, no more posture, and there was no tightness anywhere along the spine, normal patella and ankle reflexes, and head weakness, especially the right, with the power of 4 out of 5. Most of the muscle groups, and decreased sensation on light touch on the inner side of the leg. She had a positive straight leg raise. So I took her X-rays. I'm sorry I wasn't able to load them here today, but I just showed L4 and 5. I haven't included 3, 4. Just some narrowing of the intervertebral disc space. On the flexion extension, there was some instance of 3 millimeters, but no other deformity. We did an MRI, but no EEG done. And these are some of the images. So you can see at the level of L3, or actually at the level of L3, you can see what we have there. We call that spaghetti sign, and most of the time is because you can see the narrowing at the disc of the L3, 4 there. I'm going to show you this. This is the axial view. As the axial, that's what we have there. We can see the canal stenosis, and those two views. I also included other views on the other regions there, but the issue were actually L3, 4, and so this is just a look of what we have there. You can see that the dural space looks very from that. And yeah, so we had diagnosis of lumbar canal stenosis. A friend of mine was asking whether it could be like something like a tumor, but after discussion, we thought the spaghetti sign was caused because of the prognosis. So treatment plan. So because of instability, I decided to go the surgical way, and I did a T-lift at that level. These are some of the...
Hang on, before we go in surgery. Oh, you spilled it. I missed you. So go back to Spondy, the picture, that close-up. So Dr. Wohns, good morning again. And this is, again, something we will see a lot, seeing between 25, 30 patients a day in clinic, and I'm probably sure that about 10 patients will have spinal stenosis. And assume maybe your neurosurgical analytical discussion why this is not an intradural tumor based on the limited images that we have. But spinal stenosis is ubiquitous. Which leg was more affected, left or right side? Yeah. So thoughts. How do we look at this? Flexion extension films, what should we do? How should we conceptually approach this?
So I agree with your analysis that this is something we see every day, multiple times, and chance of it being a tumor is not zero, but very small. And I don't remember if you had contrast and non-contrast to rule out tumor specifically.
No contrast. Assume no.
So obviously, if you really are worried about tumor, get an MRI with contrast. And if this lights up, then maybe it is tumor. But this is probably just a compression of the cauda equina due to stenosis, more a garden variety diagnosis than an intraspinal tumor. But to rule it out, as I said, contrast study would be indicated.
All right, and can you go to the axial view? So the variables for spondylolisthesis are still not well categorized, like in a risk scheme. So what I read from the patient's complaints was mainly neurologic. There was a question back pain, but here's a unilateral facet sign. The other side looks pretty good. That's interesting. The side was radiculopathy. And there's a central disc bulge, but what variables do you look at from flexion extension films in terms of making up your mind whether this patient needs more invasive stabilization or surgery, even or just compression?
So I lean towards non-fusion treatment of spondylolisthesis of a low grade, unless it's clearly unstable, regardless of any edema in the facet joint, such as you see on the left side there. If things are stable and your surgery preserves at least half to 2/3 of the facet joint on each side, you shouldn't destabilize the spine, and the spine is not unstable to begin with. So I'm in favor of non-fusion treatment. If there's more than 3 millimeters of listhesis on flexion extension films, or if it's absolutely necessary to do a more than 50% facetectomy because of the degree of foraminal stenosis, then fusion has to be considered.
And as you say, decompression, the famous paper of Harry Herkowitz and Jeff Fishkin and others that everybody quotes for degenerative spondylolisthesis. It's probably the most over paper in the world, and the sequelae paper from that. And they talked about decompression as laminectomy. Is there differences of laminectomy versus laminotomies, where we just partial facetectomies in your experience?
Yeah, laminotomy versus laminectomy always needs to be considered what's going to be adequate to decompress the canal and the foramina. If the stenosis is such that you can just do laminoforaminotomies and preserve much of the lamina superiorly and just take the inferior portion and then open up the foramina, so be it. That's a good approach. Problem with that is quite often there's enough lateral recess narrowing and enough canal narrowing above the level of the foramen where you really need to do a more complete laminectomy. If you can get by with just laminoforaminotomies, then yes, that's a good procedure, but you don't want to shortchange the whole goal of the procedure by trying to do lesser surgery if it's not going to be adequate to relieve the neural compression, which is obviously the goal of the surgery.
Toward my partner now, Dr. O, your tube kind of eye, so less and more invasive compression, fusion, something else.
I agree with Rich. Unless there's some real dramatic instability, I favor decompression.
So, put you on the spot. So you have fusion. Tell us why. So you have to justify yourself now. So I put you on the spot, but it's an invasive surgery, and even in our country now, cost savings become a really and have been a really big deal. So this is commodity surgery almost in the eyes, not in our eyes. Every patient counts the world, but in the payer's eyes, in the hospital's eyes. So why a fusion?
I saw the flexion extension edges. I thought because of this instability, if I do just compression alone, she's likely to come probably with a progression. So that's why I chose fusion. Yeah.
And so tell us about the fusion then. So you had decompression and fusion laminectomy?
Yes, I did.
And then screws and a cage?
Yes, I did that.
Okay, show us that again. So tell us briefly about your healthcare system. So how does this get paid? Is this a patient who had insurance? Does this patient have to pay for the implants? How does this work?
In Kenya, we have what we call the social health insurance. Usually able to care for some of the minor procedures. Not able to cater for especially spine surgery because this is considered as specialized surgery, and still we have the cost of implants, which is on the higher side. So a patient normally has to have this out of pocket. Partially paid by the social health insurance for those who have, because the coverage is not it's less than half of the people are able to have this. But like for this patient, they have the social health insurance, which cater like half the cost, and then now they had to foot the bills for the implants.
Yeah. How long does the patient with the surgery stay in the hospital?
2 days. Okay. Then the third day they go home.
Okay.
Yeah.
And so that's actually pretty cool. So how the patient do?
The patient is doing okay. She's really very happy. She's doing around. So before I came over, I reviewed her. That was like three weeks after, and she was quite happy. So she was the first 2 days she was complaining of some numbness. So I put her on duloxetine and pregabalin. And right now she's doing quite okay. This was the final patient.
Yeah. Technically, very nicely done. Obviously, the discussion is decompression only versus fusion, and again, the old papers by Witz and Fishgrund are probably in need of an update, but we probably can't do prospectively randomized trials. Again, main thing for me is always looking at the patient, and when I hear mainly leg symptoms, neurologic symptoms, a question with Dr. Wohns, and some degree of back pain, I always prioritize the neurologic, because in our brain, the neurologic symptoms print more. Is that a fair generalization from a dumb bone doctor, me, dear neurosurgical colleague? So Dr. Wohns?
Nothing you say is dumb.
But what do you think? The neurologic symptoms imprint more on patients. Is that fair?
I'm sorry, I missed the neurologic what?
Neurologic. When a patient has neurologic symptoms, that registers way more prevalently in our brain than mechanical instability.
Yes, obviously, particularly speaking as a neurosurgeon, you're clued into neurologic symptoms, and that's your focus. And then once you decide what you need to do to treat the neurologic symptoms, the spinal stability issue needs to be covered. Whether there's also deformity, that needs to be covered. But generally, unless it's a high-grade spondylolisthesis, it's obviously unstable, which might be the number one reason for the neurologic symptoms. You're focused more on the pure neurologic symptoms due to the stenosis.
And pertinent to that, one of my biggest gripes that back pain is equal to back pain. It can be hips, it can be mechanical back pain, it can be a neurogenic back pain. And again, every spinal stenosis, even cauda equina patients, sometimes just present with, quote, back pain. So we have to arrive at a better definition of back pain rather than just a generic thing, because I see that used a lot as an indication of surgery. So thank you, Jeremiah, for sharing, and this nicely done, and again, subject of a lot of discussion. Who's going next? Do we want to go next, Dr. Kramer? So thank you, Jeremiah. Nice to have you here, and nice to hear perspectives, and I thought it was healthy to see. You're sitting next to me, thank you. And Dr. Kramer is a neurosurgical colleague at the University of Wisconsin, and he has, I think, 2 cases, so we'll have to accelerate the pace a little bit.
Just one case.
Oh, one case.
So, all right, so this is a case that we did fairly recently, actually. It's a 5-year-old lady who presented with intractable back pain. She had a progressive loss of mobility over the course of weeks to months. Her back pain was kind of mid-back and quite positional in nature. She ultimately, over the last week to months, was escalating her dosages of narcotics. More recently, within the last few weeks before presentation, developed some retention as well. She has pretty significant dementia, but otherwise fairly healthy otherwise. So here's her exam. You can see she's 5'4". She's only 45 kilograms. Her calculated BMI is only 17. She's a very thin lady. She had almost symmetric bilateral lower extremity weakness. You can see here. She was able to walk, ambulate within a week or 2 before presentation, but she's very progressively become bedridden at this point. You can see she's got some elastic reflexes, extremities as well. So here's her imaging. Comes in with this MRI on the left, T2 sagittal, and you get the sense that there's something at that's T8-9 disc space, which is actually better seen on the CT. So the CT shows a fairly large disc herniation at T8-9, and from the CT, it's calcified.
And how long was she paraparetic or non-ambulatory?
It's
hard.
A few weeks.
A few weeks. And it's neurogenic bladder, right?
Neurogenic bladder.
Spasticity in the lower extremity. That's what your said. So, Rich, so the question to you, and I'll ask Dr. Lashaya, is healthcare triage and resource utilization. So we're asked to be more judicious about our utilization of healthcare. It's an undeniable macro disc herniation using Curtis Dickman's famous vacation. Patient is paraparetic. The variables here are that she is quite emaciated, hectic, and she has a degree of dementia. I personally saw her also, and she has, let's just not be specific, but a physician's spouse. She has an extremely caring family, and she's interactive, but there's limits to what she can basically orient to. So how do we handle this? How do we kind of reassess this? A very, very low BMI, just on the boundary of 16, that I think all of us in the state have kind of said kind of a relative barrier to reconstructive spine surgery.
Yeah, this is a tough case. There's a lot of issues. They're not only neurological, neurosurgical, reconstructive type issues technically, but there's also moral, ethical, insurance, societal, family issues. So this is a tough case. So you have to balance all the things that you need to cover in a very fully and carefully constructed approach to the family and the patient in informed consent. So they need to make this decision. That's the definition of informed consent. You need to give them all the information that we've just gone over regarding what their choices are, what their options are, and then what the risks and benefits of each of the options are, and what is the goal here. If their goal is to do everything possible and that requires a major surgery, then you need to outline the risks of a major surgery in a patient who's obviously not ideal from the medical surgical point of view, so that they know that if they want everything done that's out there, that's possible, she could die, she could end up in the ICU for weeks, months. She may never walk again. She may never regain normal bladder function again. And so they need to know all of this. And if they say, we don't care if you don't do anything, she's going to be, bedridden for the rest of her life, which is going to be foreshortened. We don't want that. We want to give her every chance possible. If they're thinking, well, we don't want to put her through misery with a big surgery if it's not going to gain anything, and she's going to be left the same as she is now, plus have to deal with all the problems of a big surgery, then so be it. But they need to make this decision. You can give them all the information in the world, but it's their decision as to which way to go. This is not ideal. This is not something we would just say, you need to do surgery on this, because that could lead in the wrong direction for what you would like to achieve, given the risk factors here. So that's my take on it, just to be extremely thorough about informed consent and have this very caring, knowledgeable family and patient make the choice of what to do with your guidance.
Again, I'm going to really hit you hard on your surgical side here. In general, if you have a patient who has dementia, let's say a reasonably functional dementia, on the mini-mental score, she scored like at the 70%, 60-70% mark. What mental faculties declined as a patient tend to expect as a medical community after general anesthesia of, let's say, 4 hours? How much mental acuity do they lose? How much is permanent versus temporary?
That one for me?
Yes.
Right. So take a demented patient, put them under general anesthetic. They will have problems, guaranteed. And the question is, will it put them at a new lower level of dementia and cognitive functioning, or is it just temporary? You can't predict. All you can say is that they will have a problem. The thing that's unknown is, will they be able to return to at least their baseline of function, cognitive function and dementia, or are they going to be at a new lower level because of the adverse effect of anesthesia? It's usually that it's clearly temporary. The question is, how long is that temporary phase going to last with diminished function?
I'm going to go to my neighbor. So how in your society would this be handled? This is an elderly patient. She's frail. I don't know. Did we calculate the index, Mark?
I don't have the frailty index, no,
Yeah.
but it was
high.
high. We calculated.
So the body mass index is just at the boundary of not being surgical. Would you invest the healthcare dollars in the area of a patient like this? Would you say, sorry, this is a bad problem?
First, big problems are we as a patients accepting spine surgery. It's still something that is new in care, and we find that most of the times, by the time even they are coming, the therapists or the caregivers are already not for surgery. So it's unlikely. And then again, this is quite expensive. You need to, even the other specialties need to come in, and the cost and really skyrocket. So you'll probably go and go.
Okay.
Yeah.
Dr. Skuyan, so you're the attending. Yeah. So briefly, so we can move. This is a super interesting case. Dr. Wohns said it involves multiple tangents and thoroughness. So I appreciate being consulted by you, but tell us your thoughts.
Yeah, so Rich, I think this is an excellent point that you brought up. In fact, husband is a former anesthesiologist, Swedish, and they were at a very famous neurosurgery hospital, Phoenix. And he was really adamant about, he did the anesthesia for all of our cases for 15 years here before he retired. And he had her flown on a private plane and was adamant that they wanted surgery. We got palliative care. I got Jens involved, see them as a second opinion. And Jens, I don't know what your thought was about how informed family was in the patient, but I thought it was great to involve palliative medicine. That's kind of like our go-to call when we have difficulties like this.
I think the palliative care angle is a huge benefit to have. We have high quality palliative service. They are very rapid in their responses. And they bring up super important things like what are the end of life decision or ideations of the family, of the patients, if possible. Is there a living will specifically? And how do they see end arriving? And these are very well done discussions. The problem for me as patients engaged, it was literally somnolent due to a heavy load of opiates. The patient actually, which could not be mobilized, so she could not. One of my is how do they turn in bed? Then comes the step test. Sitting up out of question, but turning her created a severe neurologic type pain response. So that was actually pretty vivid for me to see. So obviously went after due diligence for surgery, but when it's a significant mobility challenge, is that something that you see not just neurologically but pain-wise? Is that something that influences your decision making in terms of recommendations? Rich, we may have lost him. So, Mark, University of Wisconsin, major academic and clinical. What would you have done there? How would that decision making have happened?
The discussion points far have been really critical, and patient autonomy is key. Well-informed decision making in this situation. I think we all recognize this patient has extremely high surgical risk. Not only from the standpoint of this really complicated pathology, it's a giant calcified disc, also from the standpoint of her kind of frailty, which again I should have calculated, which would have been quite elevated. I think also the fact that her symptoms had pretty rapidly progressed within the last month, all kind of affected kind of the family's decision making to some extent too. Like in a few months, she was able to take walks with her family outdoors, and she was actually a little more functional. And it was just fairly recently that she was loaded up on these narcotics and was almost at neuric 5 level thoracic apathy. So
so it's forward, yeah. So we did move forward.
So long story short, we did opt for surgery. We of course informed them that this would be a very high risk procedure. So we from 6 all the way down to 11 ended up a partial corpectomy at T9 in order to decompress that level. And this is a nice fly through that kind of shows you bony removal in order to get that calcified disc out.
Robotically placed screws, Dr. Oskoyan. I couldn't have done it better.
So the patient did, I'll be honest, her course is rough, actually. She had a lot of narcotic use pre-op, so it took some time to get her pain control, but definitely she did very well. The leg strength remained, actually improved pretty dramatically. She did discharge to a skilled nursing facility, and she's still recovering.
So, did you use a robot for the decompression also to see how you've decompressed?
You can actually see it on the sagittal. It was pretty amazing how accurate the drill is now.
And with the ultrasound, BK ultrasound technology, which I actually thought was really cool. And
unfortunately, using neuromonitoring, which I hate. I absolutely test using on a case like this because, of course, what happens.
Declines.
Jens, as soon as you walked in the room, what happened?
Went down. Aura. Doctor, any comments on the surgery done?
Beautiful job. Very nice. And you obviously did the right thing with all the facts laid out for all the parties involved. And had you not agreed to do the surgery, I think you would have been in more jeopardy with an angry family and potential litigation for letting her go when they wanted something done despite the high risks. So I think you did the right thing, and you did a very good job.
Actually, Rich, it's interesting. The hospital that she was at, the neurosurgeons there, it's a very famous hospital, told that it was too high risk of a surgery, and they weren't willing to do it. So, which is not. I mean, it's difficult. It's not an easy case. I can tell you that.
No.
Yeah, recovery potential on a Neuric 5. Mark had a scale there and had a MGOA inversion, also for thoracic disease. They didn't expect 2 functional grades better, but for me, the main thing was she could not. I personally examined her sometime with the family, not mobilize this patient without extreme pain, and she was heavily dosed on, you could say, overdosed on opiates. And that opiate requirement literally went down within, I think 4 or 5 days. So she was actually painfully then. So that for me, even if a patient has some degree of loss of faculties, is a big deal when they have this severe pain despite what is a more than adequate opiate load. That changes mind. Debatable, certainly, but yeah. Shall we go with Dr. Hogshead next? So thank you, Mark.
Yeah, great.
Dr. Hogshead comes to us from the DFW area. And I, which case he has, Dr. Oskoyan was so kind to look at and select some cases today. And he is mourning again. He's mourning Kyrie Irving. Irving now has an ACL tear, so Philly, a fellow who is on vacation, who is triumphant in his Eagles displays. Cameron does not have that same attitude.
Yes, Dr. Chapman, very, very state of affairs for Dallas. We're right up here. So, this is a 62-year-old female. She presented with worsening back and radiating left leg pain, and these x-rays that you can see here in clinic. She reports this was progressive the last 6 months, and also reports that she's had some recurrence of her left leg and numbness previous to her surgeries that actually resolved and improved after her endal surgeries that you can see there. She had a couple of laminotomies and microdiscectomies in 2020, and then with recurrence of symptoms again, she received a L4 to pelvis that you can see there, quote unquote, limited fusion, less invasive options discussed with her spine surgeon at that time. So you can see there her motor exam chart does have some for residual, maybe L3, radiculopathy, numbness, tingling, as well as some weakness. She is, based on ODI score, barely disabled, and a high pain interference or physical function, and not too high on her PHQ. These are her standing X-rays that presented with, and you can see her parameter on the bottom. So that's actually sadly, she's fairly balanced. MBA within 2 centimeters. There's coronal. You can see there's pretty significant degenerative scoliosis, rather large habitus there as well.
So, Rich, what's going on with our society? The numbers for adult spinal deformity are, and this is not an exaggeration, skyrocketing. Fusion or no fusion, the fusion may have not helped. I'll ask for that also. But are we operating too much as a society to unhealthy? Are we measuring too much? What in the dickens happened here?
So, difficult question, Jens. Hard for me to answer that one. Very hard to tell. I don't know exactly how to frame that one.
Fair. In your opinion, and you and I actually agreed, we're doing too many fusions. We're effectively probably fusing more than what we should. That's a fair statement. Is this maybe an exacerbation without having the benefit of older studies, having done a fusion versus meaningful decompression?
Yeah, I mean, I would totally agree with that comment without any question. In general, too many fusions are being done with no real biological scientific basis. And that's been a problem over many years. And it's only worse lately, I think, because of the factors that include safer, easier fusion technology with robotic guidance that makes it more accurate, so there's less problems putting in pedicle screws. Number one. Number two, I'm pretty convinced that because of diminished reimbursements overall, some surgeons are trying to make things pencil by being able to add additional codes, which means adding fusion when there's a choice of non-fusion potentially being as good or even better than with fusion decompression. So I hope that helps answer your question.
Yes, it does. And again, we can. Cameron, carry on. So what are we seeing here?
Well, we have an MRI here. We did discuss her renal cyst that you can see on the axial MRI. She got referral to and ended up being benign. But you can see previous hardware there. In fusion, she did have a left L5 pedicle resection for soon previous decompression, and as well as L5S1 spine. She is fused at the L4 to pelvis segments, and then she has obvious adjacent breakdown above L3, L4 levels there with collapse and foraminal stenosis bilateral.
So I also see. So I'm glad you pointed out the renal disease. This is one of those things together with aortic dilation that we really want to look at in retroperitoneal neoplastic disease. But what strikes me here is she has a relatively large subcutaneous fat layer, and she has very poor muscle tone, so sarcopenia. Question to you, Dr. Wohns, patient optimization versus the request for surgery, balance that. So this patient is obviously probably pretty deconditioned. Her BMI is suboptimal. What's her BMI like?
About 35, 36.
A1C?
A1C is okay.
Yeah. So how do we tab, as Dr. Hanscom, our partner, used to say that, versus kind of letting the patient get on their feet with surgery?
Yeah, patient optimization. The reason I'm having some trouble, and I've been dealing with Corey on this, there's some echo. So at times I just can't hear what's being said. But patient optimization, I believe, is the question on the table now. BMI of 35, that's my personal cutoff, above which I usually request some weight loss before we go into surgery. Sarcopenia, obviously in this case, deconditioning. It's hard to recondition these patients when they're having pain and issues. of a neurologic nature or claudication or whatever, they literally cannot develop more muscle, cannot get in better shape, cannot do cardio. And so it's a kind of a circular argument. How do you get them optimized for surgery? Well, it's almost like you can't in some cases because of the nature of the disease process that you're trying to treat. So as long as they're not high risk, meaning BMI out of control, totally without any activity in their life, high A1Cs, like you mentioned, not in this case. It's actually for their benefit that you go ahead with whatever procedure is indicated to get them to be able to lose weight, to get them to be able to exercise, get them off opioids or whatever other drugs they're taking, get them moving better. So I lean more towards doing whatever's necessary to get these people better so that they can be better metabolically.
That brings me to the point of bone health optimization. Do you have a miracle approach towards getting insurance companies to approve needed? I'm not sure there was a factor in here, but I'm sure she got a non-spinal DEXA scan to get approval for the expensive anabolic.
So again, I was to get approval for what was it exactly?
Anabolic, like expensive anabolic bone health drug, if needed. Do you have a magic line? Do you have a great way to persuade insurance carriers to optimize bone health?
Right. Great question. Thanks for stating it again. I usually get the help of a specialist like endocrinologist or whoever to get involved in that so that I'm not the one fighting that battle, because we have enough battles to fight just getting surgery approvals for medically necessary procedures, much less adjunctive things that we need to improve the condition of our patients that we want to take to surgery. So I'll get a consultation from a bone health specialist and let them deal with insurance approvals for expensive treatment, Forteo, or whatever else is indicated in these cases.
Cameron, carry us forwards.
Her case, her Hounsfield units at CT scan one were right at 100, and she did have a scan that said osteopenic, osteoporotic, and so she wasn't able to get, unfortunately, Forteo or Vinity or anything like that, but she was started on a heavy regimen, vitamin D, calcium, and things like that, in hopes for bone health optimization. So just in summary here, we're back, pretty end-stage spondylosis of the spine, as you can see here, has failed very vast amount of conservative treatment and weight loss. And going forward, how would you address this? She's already the limited fusion discussed with her previous surgeon. She wanted kind of the less invasive option to see how far that would get. She's kind of come to this point now and is wanting something done, whatever it takes.
Wohns,
right.
surgery.
So patient wants something done. Then you have to have goal congruence. Do you want something done? Or are you just catering to the patient's desires? Do you really feel like something needs to be done? So if you have adjacent segment degeneration, which is statistically, the diagnosis here, can you prove that, or can you treat it non-invasively, like with medial branch blocks, maybe radio frequency, or even consider spinal cord stimulation unless there's progressive neurological deterioration? And if you're treating predominantly pain or sensory symptoms, then you can do an end run around a direct surgical approach by considering spinal cord stimulation, which is not burning any bridges should you need to do a more definitive spinal procedure. So I would take all these other treatments as potential options unless there's progressive neurological deterioration, if you're particularly treating predominantly pain.
All right, those are wise words. Cameron, take us forwards.
So these are some intra-op photo of how we proceed. Our plan was for a T9 to pelvis revision fusion with eccentric, multi-level intraspinal osteotomies, as you can see there. Cages on the patient's right and left at the adjacent segments above. And you can see just from rods and cages the coronal correction that we were able to achieve there. We used a T-bar just to verify coronal balance, and so it was predominantly one of her issues, and we did lengthen her out on the right side.
All right, you.
She did very well. So she was, and this is a CT scan here, some work. She was, it was about a 600 cc blood loss surgery. She was in the hospital for 5 days, discharged, and ambulating independently with home health.
Did you utilize a robot to put these screws in so nicely?
Yeah. I don't know how we did surgery and do it with the robot.
Yes.
Yeah.
Congratulations.
Yeah.
So beautiful ideas. Now, what do you do astrally? So is there a proximal junction, kind of a security latch band, wiring?
Yeah, I did actually Marcelin tape, proximal tethers around and I wasn't able to get thoracic scan to crosslink. But there's good techniques that have shown that just two figure of eight tapes, kind of the bands that you can get. It's kind of a non-absorbable tape. You can loop through the spinous process, lamina junction, tie around your crosslink up top, and drag that for 10. And there's some good literature on that is showing less incidence of PJK. Yeah.
So patients wanting to have something less invasive and rich, their Wohns. I see a lot of cases with adjacent segment disease being treated with far lateral cage placements, which are obviously huge device that have a nice mechanical offload capability. And then surgeons trying to do percutaneous screws in the back. Is that an advancement, or is that just putting your head in the sand, or what really needs to be done if you do it? And that's good. Neurologic decomposition and carpentry and physiologic rebalancing.
Yeah, I mean, this is very well done. And this is obviously a good approach that can be used in this case and others, versus a less invasive approach. The question is, does the patient want the big hit as the first go-around to treat her symptoms? Or does she want to do a potentially stepwise approach with less invasive, fewer levels, maybe no open surgery, like I mentioned earlier? Either way is acceptable within the standard of care and effective. So in the situation where you now have done a T9 to pelvis, how long will that be successful without needing extension, more cephalad, in the setting of osteopenia, osteoporosis, somebody who may or may not have good anchors based on her substrate, her bony substrate? You just have to be realistic with the patient, saying we can do the T9 to pelvis, it'll probably make you better, but you have to be prepared for post-op at some point deterioration with either pull out of hardware, fractures, PJK, etc. And so the story is not over yet, and as you've heard already, I like the more conservative approach if it's reasonable, knowing that if you can avoid the bigger surgery, you've done the patient a favor for the rest of their life. If you've avoided the bigger surgery for a period of time, have you really helped them by doing these other non-invasive or minimally invasive procedures? That's always questionable. And then if you do need to do the big surgery, you've just increased the healthcare expenditure taking care of the patient. So these are complex problems. You did a great job on this one, and just keep our fingers crossed that she remains stable.
And this story ain't over until it's over. I want to thank Dr. Randy Davis for, this is in the chat room, so please go in the chat room. Dr. Randy Davis with other colleagues, so Dr. Fayaz, Dr. Cortaro, Dr. Benz, Dr. Shimandla are great supporters of us. Thank you so much. But he put a nice quote in there, so thank Andy, on correlation of anesthesia and mental function applications in adults with dementia. So thank you, really. This is a very cool resource. This collaboration is fantastic. Quickly, one more case, a routine case, right? Matt?
Yeah. So interesting story here. 6-year-old female. She went with persistent neck pain after a 5-foot fall. It was actually four days ago. She is a sleepwalker and actually fell from her bunk bed, and afterwards had some neck pain, was able to get up on her own, ice and sets over the home over the next day, but she just had neck pain that just wouldn't go away. So 4 days later, she was urgent care, and they got these x-rays here, and you can see C5 and C6, near 50% lysis there concerning facet fracture dislocations. See her exam them there. She was ambulatory, just some bilateral hand numbness, tingling miraculously, and some mild right extremity weakness. But
she is a survivor. I'll cut you off just in the interest of time. Jeremiah, go back. Oh yeah, here, a CT. So bilateral facet dislocation, actually you can call it for fracture dislocation, semi-ankylosed C7, site 5/6 is dislocated. Do you get an MRI scan? What do you do? This is in your urgent care now, casualty, right? So what do you do?
Traction. Yeah. So we do traction, try to see we can be able to do the reduction, and then now that should be done actually before the MRI if possible. Yeah.
I totally agree. We concur. So rapid.
MRI scan here.
We got an MRI scan. I do get an MRI scan.
With MRI scan, since the famous Frank Eismont paper in case series about a person that's actually closely reduced and resulted in paralysis, they worry about a herniation into the MRI. And so you always look for cord signal to document, and then potential for disc herniation, and then being careful with that.
This is so that everybody knows, this is the more famous case of a case report of actually 3, where the reduction techniques very questionable, if you read the fine print, which changed care for everybody.
Yeah.
Rich, bowel dislocation, how do you do that? If you can kind of, I think all of us would try to protect the patient and try to get them in the as soon as possible, at least do that. Do we need to get an MRI scan from a big picture perspective, or is it okay to kind of just go to the OR ASAP and do an anterior decompression and realignment and stabilization? What are your thoughts?
Right. You've all alluded to it. The MRI is needed to rule out disc herniation, particularly, which you won't know based on CT. And if you try to reduce each and every lock facet case, you're going to have a set incidence of causing quadriparesis or paraparesis, depending on the level, because of an occult disc herniation, which has a statistical presence in these types of cases. So I think unless there's an absolute contraindication to getting an MRI, it's always better to have the MRI, because the last thing you want to do is make somebody worse that's already gone through fracture dislocation without neurological compromise, and then you cause it by trying to make them better by realigning them.
All right, so Cameron, fast forward.
Yeah, so we proceeded with a close reduction in the OR and controlled with neuromonitoring, and just you can see the frank instability of this injury, close reduction, even prior to opening the patient up for an ADF. You can see there. After instrumentation stabilization with a plate, you can still see how distracted the facets are reduced, but there's inherent massive instability. You can see on the MRI the loss of integrity of the posterior tension band and all the interspinous ligament facet capsule. So after seeing this, which we did discuss whether we proceeded with a staged posterior lateral mass fixation as well.
So
These are upright.
great. So why'd you go levels above? If there's one level affected, she's still a pretty young patient. Why'd you go to 4? Just out of curiosity. See, I have no gripes with. That's a very semi-ankylosed level. I would use pedicle scooter, but that's okay. Why C4?
Yeah, I think if you were able to get a screw fixation, less worrisome with your question of your lateral mass fixation. And young patient, you could make as you mentioned, to minimize levels fused, just the inherent instability. We wanted to really ensure added fixation. You can see on our upright, still there's some distraction facets, and so we wanted to make extra sure solid fixation.
So, Dr. Wohns, front and back, too invasive or just a prudent precautionary additional surgery?
Right. So this is a great case to discuss because it's got a lot of teaching points. So can you do posterior open reduction and fusion as the first procedure and maybe the only procedure just at the affected level? That can be a yes. You could get by potentially just doing this posteriorly, open, reduction, fusion. Could you get by just with your first procedure, your ACDF, one level, open, reduction, and fusion anteriorly without posterior supplementation? You keep the patient in an appropriate orthosis, post-op ACDF. In this case, you'll probably be just fine. She probably won't further deteriorate at that level or at adjacent levels. To do the belts and suspenders approach, I personally believe is overkill in a young patient. You don't need to do a multi-level posterior after you've done a successful anterior. If you do anything posterior, I would stick with just the affected levels and not extend it, because from now on, this patient's going to have a stiff neck, higher chance of adjacent segment degeneration above and below. And I think it's, in my personal opinion, and it's certainly within the standard of care to do what you did. That's not the point. The point is, I think you could have gotten by with less.
Yeah, we actually just do a circular on the back when we angiofixation. I will defend this choice in terms of this looks like truly unstable, and it's extremely hard anatomic realignment of the facet joints through anterior only. I think every effort was made. This is a correct angiofixation, bicortical screws, non-variable screws, not an oversized graft. But I mean, my only small gripe is in a patient where you also don't know whether you can trust them. I think I'll use the belts and suspender technique. It makes sense to me, but maybe less levels. C7, and I would rapidly include it's a degenerated level. That's just a finer point. The big question: can you use the patient and do you make this as bulletproof as possible? Is, I think, very reasonable. Rod, what do you think?
Yeah. I mean,
More or less, or right is right?
I having done these myself, is I think it's patient, and I think in this case there was some. I think intraoperatively, I think Mir had a hard time completely reducing it. I think the option to go from the back or brace, I think are reasonable. I don't disagree with Rich or what Amir performed.
So I'll pause to Dr. Colin Gold to other cases, but we'll have to defer this to another time. So thanks for preparing them, Colin. Sorry for frustration. Want to thank our audience and our supporters, and glad to introduce Dr. Rich Wohns, MD, MBA, a true Renaissance man. And I'm not going to read through the pages of the C of his accomplishments. It's remarkable, but Amongst many things, he has been a pioneer in outpatient ambulatory surgery centers, giving surgeons a chance to actually direct care and delivery of quality care in a safe environment. He has also created angel funding mechanisms, which are remarkable. Angel MD. He is the host, convener, originator of something Mazama Spines, which I've been privileged to be part of for many, many years, which brings together thought leaders in all healthcare. That includes lawyers, executives, companies, and insurance members. A unique tank type platform in beautiful Eastern Washington. I always was interested in this Angel MD initiative, which again brings together a funding platform for developing countries. And just short circuit, he's been a great colleague here in the community, a leader in the community. He has a background at Harvard for college, and Yale from medical school, and then UW for residency in neurosurgery. He's also a avid mountain climber. He's done an appendectomy on a Sherpa in Nepal. He loves Nepal, and he's also for strong association with the Maldives. And I'm short-circuiting many of his other accomplishments, but the Renaissance man, Renaissance colleague, glad to have him as a colleague. And he has done something that is very cool. He has actually created sustainable interactions and collaborations with our colleagues in Kathmandu and Nepal, and now also in the Maldives. And that's a particularly cool thing. I'm very privileged again, part of the faculty in TUTH in Kathmandu for our monthly grounds where we interchange case discussions and lectures. So the top topic today is how do we introduce modern spine surgery to make a meaningful difference for emerging and developing countries in terms of bringing modern spine surgery to their practices. Rich, thanks for being here. Thanks for the discussion this morning. Sorry to go.
Jens, thank you so much for inviting me, number one. Number two, for getting me involved in this fabulous discussion platform that you have. What you set up with Rod, the STED talks are fantastic. And then thirdly, thank you for inviting me to speak on my focus on volunteer neurosurgery in Nepal and the Maldive Islands. And I'll start my screen sharing in a second. Soon, if I need help, Corey, I hope you're there to get it going.
Corey is there. We see the glow of your screen in your glasses. And when we see your picture.
You see the green share button, the bottom icons of your screen on your Zoom.
The green share button. I've clicked that and I have the window
Okay.
PowerPoint.
Yep.
Would Dr. Wohns have to go out and log button, or do you have the talk, Corey, as troubleshooting?
I don't have his talk.
Okay.
Let's see if I can open it up here.
You have your PowerPoint open?
We're getting there.
Okay.
It'll be just one more second and we'll be good.
Okay. Oh, that looks great.
Outstanding.
Yeah, we'll be there.
Perfect.
All right. Everybody can see that okay?
Nice. We have you may have to go into we preview pictures.
You can just swap if the top left-hand corner, it says swap screens or swap. Yep. There we go.
Nice. Perfect.
Good? All right.
Dr. Wohns,
Here we go.
platform is yours.
All right. Thank you. Volunteer neurosurgery in Nepal and the Maldive Islands is the subject for today. And I'll stick with my half hour and give you the background of what we've been doing in those two remote parts of the world. I started volunteering in Nepal through the Foundation for International Education in Neurosurgery, talking to Merwin Bagan, who's one of the past presidents of the AANS and one of the early members and chairman of the foundation, telling Merwin, I want to volunteer, I want to give back somewhere in the world. I'd like to go to Nepal, but what do you have open? And he said, well, maybe you should consider going to North Korea or Ethiopia or Mongolia, where there's two neurosurgical groups that don't talk to each other. I said, no, I want to go to Nepal. That's where I want to give back. I want to volunteer. He said, I'm glad you said that. That's where he himself set up a program in neurosurgery in the 1990s. And it turned out to be a fantastic connection that he started me out on. And I first went there in 2013. Merwin set up the program in the late 90s and trained the first neurosurgeons there, including Dr. Mohan Sharma, who did part of his training at Harborview. So the connection was great, and I went there 12 years ago with family, spent a month, brought a colleague that was working on artificial disc technology with me since he was interested in promoting the use of artificial discs in the developing world. And we flew to Kathmandu. You can all see where Nepal is. Kathmandu is the capital city. It's just north of India. It's along the southern border and into the Himalayas. China and Tibet are north of Nepal. And I had been there in the 70s, and I'll go over that history with you in a minute because that's what drove me to want to work in Nepal. Nepal's a landlocked country. It's poor. Life expectancy is good now, but used to be just even 10 years ago, way lower because of infant mortality, but that's improved. GDP per capita is still extremely low, as you can see at the bottom level of this slide. So in the 70s, I was climbing and trekking all over Nepal and then into Tibet doing Mount Everest. And I love the area. I love the Himalayas. And I was going there quite often for trekking and climbing. And in the earlier decade of this century, I told Merwin, I just really want to give back and don't want to just keep going there and touching the surface. I want to do something meaningful. And that's how I ended up volunteering at the department at the Tribhuvan University Teaching Hospital, which is the main hospital that trains residents in Nepal. So prior to 94, there was only one neurosurgeon in Nepal. First neurosurgical procedure was done in the early 60s. Then Dr. Merwin Begin's history, which I already described to you, and the training of the two first residents, Dr. Sharma I mentioned, and Dr. Shilpakar, who was a fully trained general surgeon who wanted to do neurosurgery. So those are the first two neurosurgeons in the department after their training under Merwin Begin. So the department was established. The first procedures were done at Tribhuvan University Teaching Hospital, which is the TUTH that Jens mentioned. First spinal instrumentation cases were done at that time, but the story that's important to understand is that Merwin said, Rich, when you go there and you want to do spinal instrumentation, the way you do it is you size up the need for the implants, and then you send the patient's family to the open market and have them find some stainless steel rods that obviously weren't made for spine surgery and some stainless steel wire, have them bring it to you at the hospital. You cut the rod, shape the rod, have it sterilized, and that's your spinal instrumentation. You implant that, and that's how it's basically a Lukey type construct. That's what was being done. There were no medical devices for spinal instrumentation at that time. And one of the goals I had when I started going there in 2013 was to help bring spinal instrumentation up a rung or two and bring cages and plates and screws, et cetera, et cetera. So things evolved. The department progressed. MRI was installed. 2,000 neurosurgical procedures had been performed in less than 10 years, which is tremendous. And residency was clearly established as a going concern. I was there when these doctors listed in the line first residents, Dr. Badachan, Ali Niaf, Dr. Pradhanang, and Dr. Shrestha, were either now finishing their residency or now new members of the community of neurosurgeons in Kathmandu. So I got to know these four players. Dr. Maya is the first woman neurosurgeon in Nepal, and still one of the only female neurosurgeons in Nepal. Dr. Ali Niaf, I'll go into his history in more detail because he's from the Maldives, and therein lies the connection with the Maldives that Ali and I got to be good friends. I'll talk more about him in a minute. Amit is junior faculty at teaching hospital, and Ram set up his own hospital and deals with a lot of trauma that comes in from the Himalayas, from expeditions. He also himself is a climber and has summited Everest. From those days in the 1990s, when there was a handful of neurosurgeons, to 2022, when there's now basically 120 neurosurgeons, and 2025, 130 neurosurgeons. There's more neurosurgical coverage through all of Nepal, but the concentration of neurosurgery, and particularly of spine surgery, orthopedic and neurosurgery, is in Kathmandu, which poses a problem because a lot of the pathology is out in the other areas of Nepal where there's very minimal to no coverage for spinal cases. So Tribhuvan University Teaching Hospital, TUTH, opened in 1983, built by the government of Japan, now over 700 beds, thousands of outpatient visits a day. It's the major medical and surgical services hospital in Kathmandu. Dr. Shilpakar and Dr. Sharma. This is what the hallways look like. This could be people waiting outside the operating theater. This could be people and their families waiting to get into the outpatient facility for an appointment with a neurosurgeon. The way that works is it's first come, first serve. So people start lining up at 3 or 4 in the morning to get in, and they wait. They might wait all day unless they pay $1. And $1 buys them to the head of the line. They can then pick the doctor they want to see and see somebody on a guaranteed basis. But most patients can't afford the dollar and wait in line and hope that they're going to be seen that day and don't really have a preference necessarily of the particular doctor that they're going to see. But this is how it works, and it works actually well. The people are seen first come, first serve. They bring in their medical chart. There's no Epic. It's a little pamphlet that they hand carry. They basically are the storage of medical records for themselves and their family at home. They bring in films, cut films on acetate. Really rarely will you see a CD or a thumb drive, and then there's no PAC system. So it's all the classic way of seeing pictures, which is holding up a film. Here's Dr. Shilpakar, Dr. Sharma, and now a little more about Dr. Ali Niaf. So he was chosen by the Maldivian government to be trained as the first neurosurgeon in the Maldives. Maldives, and I'll go over this in more detail in a minute, is a string of, it's an archipelago of over 1,000 islands southwest of the tip of India in the Indian Ocean. Dr. Niaf was a trained general surgeon, like so many of the neurosurgeons in Nepal, they have 3 years of training in general surgery, then do 3 or more years of neurosurgery. So Dr. Neof was chosen by the Maldivian government to be trained as a neurosurgeon because the Maldives, which had 400 to 500,000 people, did not have a single neurosurgeon. And they're, remote string of islands with a lot of neurosurgical cases. They were all having to fly out of the country to India or China or Nepal or Sri Lanka for neurosurgical care. And the Maldives government rightly considered that something that needed to be fixed, trained Dr. Neof, who is going to go back to the Maldives after finishing his training in Kathmandu. We got to be friends. He came and spent a month with us here in the Seattle-Tacoma area and went into surgery with me at our surgery center, at St. Francis Hospital also. And then I set him up with a visit at Swedish and at Harborview. And then he went back to the Maldives, went to a private hospital funded by the government in his position at the private hospital, and set up the first neurosurgical program in the Maldives. And I'll go over that in more detail. So back to Nepal, one of the first cases that I did just so happens is just like the case we saw in our earlier morning session, fracture dislocation. You can see the x-rays, the MRI scan, and the difference is in the history, this patient was injured on the job, and his job was climbing trees and picking fruit in a Western Nepali province where there's no neurosurgical care. And he fell out of the tree, fracture dislocation, no neurologic compromise, clinically seen by his local doctor in the provincial clinic, who said, here's a collar, you can go back to work, no problem. And over the month or so after the fall, he started having increasing neck pain, paresthesia in the C5 distribution, slight shoulder weakness. Went back to the doctor, said, well, I don't have anything further I can offer you, but I'll send you to Kathmandu. So he walked 9 days from the provincial location, came to teaching hospital, and took every rupee, which is every dollar he had, put it in a bag, and knew that he needed some surgery, didn't know what, but he knew that he could get free care, but not free implants. He was sophisticated enough to know, after looking at his pictures, that he was going to need some surgical procedure that potentially could cost him out of pocket, because the government insurance does not cover implants without patient contribution, and it could be complete payment of the device costs. Yet the hospital bed was going to cost him a minimal amount, if anything, and he knew that he could get the bed, but he knew that he also needed to cover cost of implants. So he brought everything that he worldly owned, and we saw the patient and basically told him what he needed, and we did a less costly procedure. We did a posterior reduction as much as possible without any implant, and then flipped him over and did an anterior construct. And Dr. Shilpakar explained to the patient, you're really lucky Dr. Wohns is here. He brought cages, plates, and screws for us to do an anterior only procedure. And we reduced as much as we could, used him with the free contributed, donated implants that you see here, and he did great. And we were able to keep him in a collar for 6 weeks and then wean him out of the collar. He was able to go back to work. Key thing with these folks is that they don't have disability insurance or anything. And if they're the lifeline for the family as far as earning, They contribute all the money to the family. Their main goal, no matter what, is to get back to work. So we achieved our goal. We reduced him as much as possible. Not perfect. We fused him, and it was successful. And he was able to get back to work. So we won on this one, and the story was unbelievable to me, but was repeated multiple times over the years in terms of the hardships these folks have getting care, getting in to be seen at all, and then getting proper implants. So I taught minimally invasive discectomy, which was a low-cost approach. So I was showing them how to put in a minimally invasive retractor, and we did this case. That was the first one in 2013. Always time off is important when you're doing work like this because the culture in the area around you is unbelievable. So always a visit to a temple or a World Heritage Site or just a walk through the city brings you into amazing situations with phenomenal architecture, beautiful people, and interesting scenes. So I've been to Nepal so many times, but I always take time to walk around. I bring guests, associate spine surgeons, neurosurgeons, monitoring people, medical device company people, others, and make sure they see the wondrous sights of Kathmandu. I invited Merwin Bagan and Sushil to one of our Mazama Spine Summits, where we highlighted the work that Merwin started in Kathmandu, and Sushil continued. He became chairman of the department, and these were great talks that excited the audience to hear right from the horse's mouth. And then going back year after year, sometimes 2 or 3 times a year, I became visiting faculty at teaching hospital. And then I started going to the Nepal Society of Neurosurgeons meetings and always providing lectures, either clinical or by their request, medical legal, because they knew I was also a lawyer and did a lot of medical legal work, and they were having trouble with medical legal issues in a country that does not have a due process protection of patients or of physicians. So if you have an aggrieved patient or family with a bad outcome or an untoward outcome, the way the family would handle it, they would do ad hominem attacks on the doctor. They would stand outside his home, and when he would come out of his door, they would have the media there, TV, newspapers, and throw eggs and tomatoes and call him a butcher. And that was the way they tried the case. They just tried to destroy the doctor's reputation. Obviously, this is totally incompatible with modern life and the way things that should be done. So they had me lecturing on how to set up some sort of medical legal system to protect patients' rights and also physician rights, but also deal with other matters like credentialing and peer review and medical commission type work. For full disclosure, I'm on the Washington Medical Commission. We look at complaints by patients against physicians. So we started talking about how to do all of this in Nepal, and slowly things have improved, but there's still issues, but it's better. And trying a case in the court of the public with the media and newspapers still happens, but it's better than it was. It was unacceptable when I first went there in terms of what families would try to do to the reputation of well-meaning doctors that might have had a bad outcome with no fault of their own. So the neuro ward has improved also. It's now a major presence, and that's thanks to other people that increase the presence of neurosurgery in Nepal. Dr. Devkota trained at Atkinson Morley Hospital, where one of your prior Swedish attendings, Dr. Dave Newell, spent time as a year away from the residency under Dick Wynn at the University of Washington. Dr. Devkota then built his own hospital, further improving the status of neurosurgery in Kathmandu. Dr. Henry Marsh, you may all have read one or more of his books. He's a now retired neurosurgeon from England who did also similar volunteer work in Nepal and also in Ukraine. He's a great friend of Ukraine, and he wrote the books Do No Harm, Death and Brain Surgery, and then Admissions, Life as a Brain Surgeon. And then recently, he wrote kind of an end of life book, which I didn't include here, which I just finished reading when he got his diagnosis of stage 4 prostate cancer with metastatic disease and what it was like for him to become a patient. It's phenomenal reading. So here's another benefit to being in Kathmandu. You can trek. You can trek in Nepal. You can go up to Tibet. And having been to both places, I always wanted to go to Bhutan. So it's a 1-hour flight to Bhutan from Kathmandu. It's not like you need to fly from Seattle and go to Bhutan and make a huge trip. I'm already in Kathmandu, 1-hour flight along the southern border of the Himalayas. I land in Bhutan and I can go trekking there for a couple of days, see one of the most incredible sites, a monastery built on the side of a cliff, Tiger's Nest, and then fly back to Kathmandu and resume work in Kathmandu. So it's a great center to get out into the Himalayas. You can go trekking throughout all of Nepal. You can go to Bhutan, you can go to Tibet. So where else can you go? Well, as you can see where Nepal is, Maldives is almost straight south of Kathmandu. So started going to the Maldives on invitation from Ali, who wanted to set up a similar thing to our Mazama Spine Summit and create a meeting, but also do live surgery. When he first started, there was no confidence in a Maldivian surgeon trained in Kathmandu who came back to the Maldives to set up a practice in neurosurgery. And patients weren't coming. They would maybe come for a carpal tunnel. So for his first year, that's all he did was carpal tunnel surgeries. If there were brain tumors or aneurysms or even major trauma, and certainly spine surgery, nobody was coming. So he invited me to come to the Maldives and set up a meeting where we did live surgery and lectures. So Maldives is a really unusual place. It's got a sea level altitude, literally 1.5 feet above sea level, in contrast to Nepal, which is in general over 10,000 feet. Kathmandu is about 4,500 feet. But as you know, Mount Everest is in Nepal and Tibet at 29,000 feet. And there's most of the 8,000 meter peaks in Nepal. So huge contrast to the Maldives, which is pretty much on the equator, a lot of islands, and right there at sea level. Higher GDP. It's a well-educated country, and now close to 600,000 people. So Ali worked at this private hospital, but not getting any cases. And he really wanted to build up spine surgery, brain surgery, and not just do carpal tunnels. So I went over there, flew down from Nepal on one of my visits there, and we set up the first Maldives Spine Conference initially, and then it became the Brain and Spine Conference. It was a small little boutique conference initially with only 5 speakers, a couple countries represented, 30 attendees. But the live surgeries that I performed to teach the procedures had 65,000 viewers via the live broadcasts and social media. And so all of a sudden, Maldivians realized Ali is working with this person from the U.S. and he knows how to do these procedures. He was trained in the procedures, and now we've seen them being done right here in the Maldives. So all of a sudden, he was able to start getting more referrals and started building up his practice. And he became literally too busy after a few years and had to bring in 2 more people. And this meeting became a yearly event. I'll tell you about one case, and I think Dr. Chapman and Dr. Askuian have heard me talk about this story. So I did the first cervical disc arthroplasty at this spine conference, and I asked Ali to tell me what's the clinical history of the patient, show me the films before I landed in the Maldives to do the surgery. He said, "Don't worry, Dr. Wohns, it'll be okay." So I had to go on faith. And we all like preparation. Well, I didn't get any preparation, but I landed and I said, okay, I want to meet the patient. I want to see the films. Otherwise, I'm not doing this cervical disc arthroplasty. I want to make sure indications are proper, et cetera, et cetera. So this turned out to be Ali's anesthesiologist. And Ali could not do any surgery for a few weeks before we were going to do this surgery, because the anesthesiologist had severe radicular pain every time she tried to intubate someone because of the degree of nerve compression she was experiencing. So I looked at the films and, the patient, and it was like the perfect case, young, healthy, 1 level. And I don't have the pre-op, sorry, but as we were wheeling her back into the operating room, she said, Dr. Wohns, I'm not afraid of the surgery at all. I'm only afraid of the anesthesia. So I thought that was pretty funny. We went ahead and did the surgery. She did great, went back to work in a week, and everybody was happy. So the next year, we started creating a bigger meeting in Nepal also. So it was kind of a theme, create a bigger meeting, live surgeries, more attendees. So I was doing a similar thing in Nepal with the teaching hospital people. And I think my time's going to be up any minute now, isn't it? We had lots of attendees, live surgeries. We started showing how to do both open and minimally invasive instrumented T-lifts. I did a Protis C, first one in Nepal, huge disc herniation. And again, always took the time to go out into the community, to see the sights, to see the colors, to see the people. This holiday is a must experience for everybody. Holi, Holi, Festival of Color, unbelievable experience. You walk down the streets and all these little bags of color, people carry them with, and they throw them at you. So you come out looking just like the people in this picture. I helped at the National Trauma Hospital. They asked me to help give a mock exam to their chief resident who was going to be sitting for their boards. We, as I said, increased Spine Week to a big conference. This is the number of people we had at Spine Week 2018 in Kathmandu. We did the first anterior lumbar. Another incredible trek, the Mustang, which is a previously cordoned off valley in western Nepal. We were the only trekkers there. I went with one of my sons. There was no one else. We visited 600, 700-year-old monasteries. And then I'm kind of showing you the sequence, the growth of the Maldives meeting. We had 30 speakers the second year, 7 countries instead of 2 countries. It's Instead of 30 attendees, we had 150 attendees. This was the next Maldives meeting. Did the first anterior lumbar approach with arthroplasty on a soccer player. We did the first ALIF on a little lady with severe degenerative disc disease and low-grade spondylolisthesis. 2019, we did numerous other procedures. I'll try to go through this quickly. We did the first SI joint fusion, follow-up arthroplasty, and I'll just leave this thank you note for you to read for a second, because this is the type of thing that keeps you going. Spine conference in Nepal. So we're doing this sort of thing every year now. You see Dr. Farouk Faroki, Dr. Rick Chua. These are American spine surgeons, neurosurgeons that have been starting to come with me every year in both Kathmandu and the Maldives. They're part of the foundation that I created a few years ago as a 501c3 nonprofit to promote teaching of spine surgery in Nepal. They're board members, along with Amit, who is the neurosurgeon shown here, with the first big PLOTS case that we did as a group. We brought a neuromonitoring specialist from the Seattle-Tacoma area, and this woman had not walked for 9 months, and we did her in the least invasive way possible, because we had no blood and no ICU access for her particular case, but particularly no blood. So we did the least that we could do, which is just a posterior, basically deformity correction and instrumentation, no anterior surgery. And she walked, and family sent us a video of her walking for the first time. After the surgery, she walked about a couple weeks after surgery. It was pretty emotional for the family. She was totally non-ambulatory for 9 months. So we also created, and Jens alluded to this, monthly Zoom meetings where Jens has talked, Rod Askurian has talked, and we have numerous other folks who are guest speakers, half-hour presentation by us, and then 2 resident presentations where we learn as much as they learn from us. We do Spine Week every year, lectures, surgeries. We have a numerous amount of donated equipment from various companies that you can see here that we bring. We have fabulous interactions with the residents and fellows. We continue this. Our next one is in December. Anybody interested, please let me know. We're always able to fit in 1 or 2 people. We keep the group small just because physical plant is not set up for high grade population of visitors. This December, we're actually teaching endoscopic spine surgery. My partner, Dr. Nwosu, is coming over, is going to teach endoscopic spine surgery. We've taught them MIS, as I mentioned earlier. They're now doing it on their own. That's our goal. The goal is not to just do surgery and leave, even after staying a week or 2 or 3. Our goal is to teach new procedures, get them totally up to date on how to do it, confident and replicable, and have them do it on their own. But when we go back on interim trips between spine weeks, we make sure they are fully comfortable with the procedure. Here's the not-for-profit. I already mentioned that. And I better quit at this point because I'm already 10 minutes over time. I'm sorry about that. But let me just thank everybody for their attention and thank Jens for inviting me to speak at this fabulous STED talk that you've set up. And I suspect there's no time for any questions, but let me know if there's any maybe single question, Jens, if there's anything you'd like to
Yes.
go over. But I've gone over my time, and I apologize for that.
No apologies necessary. This is an absolutely wonderful interpretation of D as in discovery. That D is always multifunctional. So thank you, Rich. I'm going to ask a question to our honored visitor, Jeremiah from Kenya. What do you, and this goes to Wohns and everybody, what would you like to see as a surgeon specialist in Kenya from people like us in the US in terms of how we support your mission as being an excellent spine surgeon? What would you to see?
Thank you very much for the question, Dr. Jens. We say you teach to fish because you can't give fish all the time. I think training, just like I heard doctors doing in Nepal, this is very encouraging. I remember, actually, the reason I'm here today is about this place through Invasive Foundation. I was sponsored even to come here for a training back in 2017. And then you and Dr. Rod came to Kenya. You taught us quite a number of things when I was a resident. And we yearn for knowledge. The more we get to be taught how to do these things on our own, the better it is, and the more the population cover. Because what we lack in the third world countries is actually the training. Like in Kenya right now, we don't have any like a spine training fellowship center. And these foundations help us when they bring knowledge back to the people and the surgeons who are there, so they can continue empowered to do more on their own.
Well, we're honored to have you here. So, Rich, any thoughts on what Jeremiah, I mean, you immediately had continuity and ongoing dialogue and exchange, and Zoom/Teams media are obviously very helpful in this regard. So you've already in business, but how do you make start? Should you just jump on something that exists? Should you develop something new? And how does industry support this?
Yeah, industry is very supportive. They've been fabulous partners, numerous companies. That's important to have them continually involved. The reps from the companies go with us frequently to help with teaching use of the new devices. Your ongoing relationship with Nuvasiv and with Dr. Jens Chapman and Dr. Rada Skuyan, it's Swedish, Seattle Science Foundation, critical. Keep the dialogue open, keep the teaching two ways, because we learn from you, you learn from us. It's great collegial activity. Visits for you here and for them there are really helpful. Giving lectures on site, having you give lectures here. This is what we've done. This has worked very well. You're doing it, and you can amplify it even more if you'd like, and if everybody has interest and energy. It's a very, very rewarding and gratifying two-way relationship. On that note, they're waving me into the operating theater here. I better run, and we could talk all day on these issues, and I'm happy to talk more offline, but I better go. And once again, thank you so much for the honor of presenting today.
Thank you, and thank you all for your support and interest. And Nepal Spine Foundation, great opportunity to get engaged. Have a great day, Rich.
Take care.
Always good to see you. Be well. Well done.